In addition to the lecture on bone and joint infections, I'm going to give you a shorter lecture on endocarditis and other intravascular infections. Please feel free to email me with questions. My email is laura.certain@hsc.utah.edu. Endocarditis, it technically refers to inflammation of the endocardium, which is the lining of the inside of the heart chambers and along the heart valves, though in practice it refers to an infection of the heart valves themselves. So you can see in this cartoon there's an infection on the heart valve. We usually call that a vegetation in this context. This is an echocardiogram, an ultrasound of the heart showing a vegetation on the mitral valve. So you've got the left atrium and the left ventricle labeled, and then the black arrow is showing the mitral valve, and the white arrow is showing a large vegetation, or Goomba is the non-technical term for it that is often used, on the mitral valve. So this would be a case of endocarditis. The way endocarditis starts is that bacteria in the bloodstream attach themselves to the heart valve. So transient bacteremia is actually relatively common in humans. So there are many causes of this. So eating, brushing your teeth, dental procedures, surgical procedures, especially those on the GI or GU tract, really anything where you're causing trauma, even microtrauma, to surfaces of the body that are heavily colonized by bacteria. Any of those can lead to a transient bacteremia. And occasionally, those bacteria in the bloodstream find their way to a place where they shouldn't be. So in previous lectures, we talked about osteomyelitis and prosthetic joint infections. So those bacteria from the transient bacteremia might find their way to a joint or to some vertebrae, or they might attach themselves to the heart valve. Now, those bacteria attach far more easily to sites of prior damage. So in fact, in animal models, it's really pretty difficult to give an animal endocarditis unless you have previously damaged their heart valve. So the idea is that you have the endothelium covering the heart valve, and it has a site of damage that maybe has a little bit of a fibrin clot on it, and then the circulating bacteria attach to that clot, and then that attracts more of the coagulation cascade, maybe some platelets, and then that attracts more bacteria, and then it builds up into the vegetation that can be seen on the echocardiogram. Now, by far the most common risk factor for endocarditis is prior endocarditis. So if you've had a prior infection on your heart valve, that generally leaves some residual damage on the heart valve. So patients who've had a prior heart infection are more prone to a next one. In addition, patients with prosthetic valves are more likely than patients with native valves to get endocarditis, or patients with congenital or rheumatic heart disease that can lead to either valvular dysfunction or turbulent flow in the heart that in and of itself over time sort of can traumatize the heart valves. So all of these are risk factors for endocarditis. That said, most people who get it don't necessarily have any of these risk factors. Once the endocarditis does develop, this is some pictures of what it looks like histologically. So on the top row is some images of streptococcal endocarditis. The panel A is the lowest magnification, so you can sort of see the healthy valve sort of on the lower half, and then the vegetation with the arrow pointing at it, and then zooming in on B and C, you can see the gram-positive cocci inside that vegetation. And then in panel D, E, and F are just some images of other types of bacteria that can cause endocarditis. If you look in the notes section of this slide, you can see what they are. One is, on the left is C. acnes, and on the right is Whipple's disease. Endocarditis is relatively rare. It's estimated about 3 to 9 cases per 100,000 people. It is more common in men. Risks include the things we talked about, prosthetic valves, if you have an intracardiac device like a pacemaker, for example, unrepaired congenital heart disease, or history of endocarditis. Also, IV drug use, as we'll go over the next couple slides, is a huge risk factor for endocarditis. As you can imagine, if you're injecting bacteria directly into your bloodstream, along with maybe little bits of foreign material that might cause damage to your heart valve, you're at high risk for endocarditis. But again, as we said before, 50% of cases develop in patients with no known history of valve disease. With the opioid epidemic, the incidence of endocarditis from IV drug use is increasing. So this is data from North Carolina looking at the incidence per 100,000 cases attributable to IV drug use. So you can see originally the old epidemiology sort of said 3 to 9 cases per 100,000 persons per year. But as you can see from this, now we have basically that many cases just among patients with IV drug use. And as a side, Staph aureus bacteremia, most of these are Staph aureus, as we'll get to in a moment, leads to a subsequent prosthetic joint infection in 20 to 25% of patients. So all these patients with endocarditis and therefore bacteremia may also end up with a prosthetic joint infection should they have had a total hip or total knee replacement. So which bacteria cause this? Here we have a chart of which organisms cause endocarditis according to the different ages. So as you can see in the blues are the streptococci, and in green is Staph aureus. In general, it's gram-positive organisms that are by far the most common causes. And as we'll go to in a few slides, whether streptococci or staphylococci are more common depends a little bit on the mechanism of how the endocarditis began in the first place. So in native valve endocarditis, so the NVE stands for native valve endocarditis, in non-IV drug users, it's mostly streptococci, so either oral strep like strep mitis or other streptococcal species, and then Staph aureus also makes up a sizable proportion. In IV drug users, it is almost always Staph aureus. So for whatever reason, even though staph and strep both live on our skin and staph epidermidis lives on our skin, in IV drug users, it seems to be Staph aureus that is most commonly the cause of the bacteremia that leads to endocarditis in these patients. In about 10% of cases, we aren't able to identify the organism by blood culture. So the typical way that we diagnose these is by collecting blood cultures and seeing what bacteria grow out of the bloodstream. However, sometimes nothing grows, and this is usually due to prior antibiotic exposure. So they've been on antibiotics and therefore their blood cultures have been sterilized. But it can also be due to difficult to culture organisms. So the so-called HASEC organisms, which are Haemophilus, Aggregatobacter, Cardiobacterium, Eikenella, and Kingella, are traditionally the ones that people will ask you questions about on rounds. So these organisms traditionally have been difficult to culture. That said, with more advanced culture mechanisms, we often do grow them these days. The bacteria in the right-hand column on this slide, so Bartonella, Brucella, Coxiella, and Trophorema whippleyi, are still very difficult to culture, but so those are often diagnosed by serology, so by looking for antibodies to Bartonella, Brucella, etc. Fungal endocarditis can also happen. Usually it's Candida, occasionally Aspergillus. It has a very poor prognosis when it does occur, and almost always requires surgery to remove the infective valve, and then sometimes lifelong antifungal therapy as well. The canonical symptoms of endocarditis are fever, chills, and sweats. And by chills and sweats, we mean shaking chills or rigors. If it's subacute, weight loss and fatigue over weeks to months are common. It can also present with symptoms of embolic phenomena. So if you think about it, if you have a vegetation on your aortic valve, then it can flick off little bits of that vegetation to other parts of your body, and that can cause stroke if it goes to your brain. It can cause septic arthritis if it lodges in one of your joints, and as we'll discuss, it can also cause some skin manifestations of emboli. A heart murmur as well is a sign, not a symptom, of endocarditis. And new onset heart failure, if the valve is damaged enough, patients might have symptoms of shortness of breath or volume overload because their heart valves aren't working very well. The main way to diagnose it is by blood culture. So these are a picture of what blood culture bottles look like, because if you imagine, right, if you have an infection on your heart valve, the expectation is that you will have bacteria in your bloodstream. In fact, sort of persistent sustained bacteremia is one of the hallmarks of endocarditis. So often with the initial presentation of a patient with fever, chills, sweats, maybe a new murmur, it is very important to get blood cultures prior to starting antibiotics, right? Because as we talked about, if you start antibiotics and then check the blood cultures, your blood cultures might not grow anything because they're mixed in with a bunch of antibiotics that have killed off all your bacteria. So ideally, when the patient comes in, you collect blood cultures prior to starting antibiotics, and ideally, you are collecting 2 or 3 sets of them from different puncture sites. So it's not just that you stab the patient once and draw 3 sets of blood cultures, it's that you take one from the left arm, and then another set from the right arm, and then maybe another set an hour later from the left hand or something. And because we basically just want to capture the bacteria, if you fill the blood culture bottle appropriately, which is often like 10 cc's of blood, you will increase your yield of the cultures. In addition to blood cultures, echocardiograms are probably the other mainstay of diagnosis. An echocardiogram can either be transthoracic, this is sort of the traditional echocardiogram, it's a non-invasive procedure, or they can be transesophageal, where they put the ultrasound down through the esophagus and so can get a look at the heart from the posterior side. A TEE is more sensitive for endocarditis, especially for looking at certain valves, but it's an invasive procedure and it is not without risks. In general, it's fairly safe and well tolerated, but you can damage the esophagus in doing it. Now, all patients with suspected endocarditis should get a TTE, a transthoracic echo. Exactly when and who should get a TEE remains debated. If you're interested, there are lots of articles on it. You can read about it. But basically, if you think about endocarditis, you should get a TTE for sure, because if it's there, if it shows a vegetation, you're done. We typically reserve a TEE for patients where we're concerned about endocarditis and we want to rule it out so that we can shorten their antibiotic duration if they don't have it. There's also Duke's criteria for diagnosing endocarditis. So the major criteria are positive blood cultures, so more than one set of positive blood cultures with an organism that typically causes endocarditis, and vegetation seen on echocardiogram, or new valvular dysfunction that isn't otherwise explained. The minor criteria, somebody who has a risk factor, a fever, evidence of vascular phenomena, I'll get to what Janeway lesions are in a minute, immunologic phenomena, so effects of having the immune response to endocarditis, or just a positive blood culture that's not with a typical organism, or you only have one and not more than one. The diagnosis is considered made if you have both major bacteria, right? So if you have positive blood cultures with a typical organism and a vegetation on echocardiogram, then you have endocarditis, end of story. It can also, if you have one major criteria and 3 minor criteria, it's also considered endocarditis, and if you have all 5 of the minor criteria, so then that's also considered positive for endocarditis. Janeway lesions and Osler's nodes always come up in discussions of endocarditis. So Janeway lesions are these painless macules on the palms and soles. It's thought to be evidence of, they thought to be a result from embolic phenomena. So these are just some pictures I found online, but basically it's if you have a vegetation on the left side of your heart and it's flicking off embolic phenomena to your fingers and toes, this is what it looks like on exam. Osler's nodes can look pretty similar, but unlike Janeway lesions, which are painless, Osler's nodes are painful. And these are actually thought to arise from immune deposits. So if you think about it, if your body is trying to fight off this like massive storm of bacteria in your bloodstream, your immune system tends to be pretty activated. You have a lot of antibodies circulating, and all those proteins tend to deposit in your skin and cause these painful nodes. I will say, whether that's exactly what they are, unclear, but they are associated with endocarditis. And then finally we have raw spots, which are basically like Janeway lesions, but in your retina. So it's a retina infarct with central pallor, so the white spots you can see, and surrounding hemorrhage. So the white spots surrounded by hemorrhage, so those are raw spots. And again, so these are sometimes seen on ophthalmologic exam in patients with left-sided endocarditis. And in fact, I have a patient who was initially diagnosed because he was having eye symptoms, went to an ophthalmologist saw raw spots and sent him to the ER due to concern for endocarditis, which he did end up having. This was a patient of mine who had a bicuspid aortic valve, and so he was at higher risk for endocarditis because he had an abnormal aortic valve, and he ended up having streptococcal endocarditis from an oral streptococcal infection. In addition to the eyes and the fingers and toes, cerebral embolic events are actually fairly common. So this on the left is a picture of an MRI with somebody with brain abscess due to septic emboli to the brain. This is a paper where they looked at 56 patients with endocarditis, and regardless of whether they had clinical evidence of a stroke, they did an MRI on many of them. So they evaluated, of the 42 who had no clinical evidence of a stroke, 27 of them got a brain MRI anyway, and of those 27, 19 had MRI evidence of embolization to the brain. So just pointing out that these emboli to the brain are actually very common, and the reason that matters is that sometimes these patients with infections on their heart valve need to undergo surgery. And in order to undergo heart surgery, you have to be put on therapeutic anticoagulation so that you can be put on bypass and your blood doesn't clot the bypass machine. However, if you've had septic emboli to the brain, or if you have like a mycotic aneurysm in your brain, you are at much higher risk for bleeding when put on anticoagulation. So if you have a patient who has endocarditis and might be undergoing valve surgery, it's important to image their brain first so that you can better assess the risks of putting them on anticoagulation for the surgery. The treatment of endocarditis is generally with antibiotics. Surgery can also play a role. There are guidelines for the treatment of endocarditis. There's the link there. They were last published in 2015 and put out jointly by the American Heart Association and the Infectious Disease Society of America. In general, I'm not going to go through every recommendation because you are perfectly capable of looking up and reading the recommendations on your own. But in general, patients with endocarditis are treated with 2 to 6 weeks of IV antibiotics. The exact choice and duration of antibiotic depends on the bacterial species causing the infection and whether it's native versus prosthetic valve. In addition to antibiotics, surgery is done. So basically surgery to remove the infected valve is done if the vegetation is bigger than a centimeter in size, if there are ongoing emboli despite antibiotics, if there's severe valve dysfunction, right, so if the valve is so damaged that, even separate from any infection, they would need their valve repaired anyway, or if they have a large paravalvular abscess. So sometimes the infection, even though it starts on the valve, can progress to the area around the valve and sort of cause an abscess in the heart tissue next to the valve, and that can then cause total valve failure, or in rare cases cause a ruptured aneurysm in the heart. Now, in general, everybody with endocarditis is treated with intravenous antibiotics. That said, there was a study that came out in the past couple of years looking at transitioning patients to oral antibiotics after they have stabilized. So this is called the POET trial for partial oral treatment of endocarditis. I'm not sure how that actually spells POET, but it is called the POET trial. It looked at 400 patients in stable condition who basically had done well. So they'd gotten at least 10 days of IV antibiotics. If they'd had surgery, they'd gotten at least a week of antibiotics after the surgery. They were feeling well, their inflammatory markers were looking good, and basically everybody thought they were doing fine. And they were randomized to either IV or oral antibiotics. So these were patients with streptococcal, intercoccal, or staphylococcal bacteremia and endocarditis. They were stable and had received at least 10 days of IV antibiotics, and then they were randomized to oral versus IV. And it is worth noting that all patients in the oral arm received at least 2 antibiotics, so they were treated with 2 different oral antibiotics simultaneously, and they were treated with very high doses of oral antibiotics, much higher than we typically use for routine infections. And there was, in fact, no difference in outcome. So their primary outcome was looking at mortality or a recurrence of the infection, and basically there was no difference between the IV arm and the oral arm. So maybe oral antibiotics are okay after patients have received their initial IV therapy. That said, the standard of care in the US is still IV antibiotic therapy. The way the POET trial has been applied here is that for patients who, for whatever reason, they can't get IV antibiotics, either due to insurance reasons or antibiotic allergy reasons, they're allergic to all the IV ones, or they're thought to be at high risk for misusing their PICC line, which is the peripherally inserted central catheter. It's sort of the long-term IV that is used for giving long-term IV antibiotics. In those patients, and patients where for whatever reason we can't give them IV antibiotics, we typically rely on the POET trial to tell us, well, okay, which oral regimen might we be able to get away with? And with time we may start using oral antibiotics more, but for the moment the standard of care in the US is still IV therapy. The question that will often come up for you is who should get antibiotics with dental work, right? So the reason why some patients get antibiotics with dental work, separate from the prosthetic joint infection question, which we covered in a different lecture, is to reduce their risk of endocarditis, right? It says we know that dental work can cause transient bacteremias, and these bacteremias can cause a heart infection. That said, there's more and more evidence that we are, sort of more likely to give somebody C. diff colitis or an antibiotic rash or anaphylaxis even than we are to prevent a single episode of endocarditis. So in recent years, the recommendations surrounding antibiotic use with dental work have really become much, much more narrow. So listed here are the categories of patients who should get antibiotics with dental work. The main one are really patients with prosthetic heart valves or other prosthetic material in their heart, or a history of infective endocarditis. So those are really the main 2. In addition, some cardiac transplant patients warrant it, and patients with unrepaired congenital heart disease. And then additionally, or repaired congenital heart disease that still have abnormal blood flow. Again, the idea here is that patients with abnormal or regurgitant blood flow, that the turbulent flow can cause additional trauma to the heart valves and render them more prone to infection. So I want to spend a few minutes talking about Lemierre syndrome because it's another endovascular infection, and it is one that is associated with oropharyngeal infections. Lemierre syndrome is septic thrombophlebitis of the internal jugular vein, and it typically occurs in young, healthy people after an oropharyngeal infection. It is usually caused by a bacteria called Fusobacterium necrophorum. So this is an anaerobic, non-spore-forming gram-negative rod, and it's commonly found throughout the alimentary tract, so mouth, esophagus, all the way through your gut. It can also cause pharyngitis. So typically we think of pharyngitis or sore throat as being caused, well, by viruses primarily, or by group A strep, especially in young people. But when people have actually looked to see which organisms are causing pharyngitis, Fusobacterium necrophorum is actually a fairly common cause of sore throats, both in young adults presenting to a student health center at a U.S. university and at adult primary care practices in Sweden. This is one reason why if you think a patient has strep throat, you should treat them with penicillin, not azithromycin, because penicillin treats both group A strep and Fusobacterium, whereas azithromycin only treats the strep, and even that, not that well. Septic emboli are common in Lemierre syndrome, and it is typically treated with IV antibiotics, usually beta-lactam and metronidazole, and surgical drainage or debridement. So what typically happens is a patient will present, they'll have had a sore throat or maybe a little bit of a dental infection, and then maybe that'll start to get better, and then they get super sick, so fevers, low blood pressure, and then neck pain from the infected clot in their jugular vein. The diagnosis of Lemierre syndrome is typically made by blood culture, so growing Fusobacterium or sometimes another pathogen in blood culture bottles, and imaging, so typically a CT scan of the neck and chest. And I include the chest just because it is fairly common for these patients to have emboli to the lungs as well. So it's a clot in the jugular vein, so that can go to the right side of the heart and from there to the lungs. So the summary of this little mini lecture is that endovascular infections like endocarditis or septic thrombophlebitis, of which Lemierre syndrome is one example, are diagnosed by blood cultures and imaging, whether that's an echocardiogram or a CT scan. And while these infections are rare, oral bacteria are a common cause. Because of that, select patients should get antibiotics prior to dental work to reduce the risk of endocarditis. And also, young patients are at risk for Lemierre syndrome after oropharyngeal infections. So should you see a young patient with a recent sore throat or dental infection who suddenly seems way sicker than expected, it's important to recognize that they could be having a rare but life-threatening complication for that infection. All right, thank you for your attention. Stay safe, wash your hands, and I hope next year to see you in person.